PICU cases, emergency cases in the pediatrics. And we have our expert, Dr. Shoumen Meu and Dr. Ognishekar Saha. With them, we have mentors like Dr. Satyabrata Rai Chaudhary and Dr. Shatarupa Mukherjee. They are experts in the field of pediatric intensive care. And the presenters today are Dr. Shreya Haldar and Dr. Bhaskar Banerjee. So I will request Shreya to start the session. And before that, I will request expert Dr. Ognishekar Shah and Dr. Shoumen Meu to say how to proceed for the presentation. Over to you, Ogni.
Yes. Good evening, everybody, and welcome. So this is a new initiative that we have started for some time, and it has been quite well received, actually. So the concept is that some cases will be presented, and we will cover them quite extensively, so that we have about 1 hour for each case. So we'll go in quite depth, and we'll see how the case has proceeded and how it has flown. And then in between, we'll try to figure out if there are areas which could be addressed a bit differently, which could be addressed maybe in a somewhat better way. And then if there are some other parts which could have also been covered, something like that. So how it could have been done in a different way and maybe in a better way, and also what are the things that we have done well. So and we'll go quite deep into it. So that's the idea. It will flow, and then me and Shominda, who is senior to me, again sort of absolutely expert in the field. So we will possibly give our inputs wherever we feel like. And Shatarupa and Satyabrata, they are there. They are almost like a defense counsel. So they will like try to sort of, yeah. So that's the thing. So we are the bad cops, me and Shomenda, and Satyabrata, Shatarupa, they are the good cops. So that's the format. Shomenda, if you want to add something, feel free.
Yeah, Dr. Meu.
Yes, thank you, Agni. Yes, I'm a little bit senior to him, but no, I think it's an excellent initiative, and the fact that we have got 1 hour is a good thing, because sometimes, not sometimes, often we have these discussions which are very time limited, like we have got 20 minutes, 25 minutes per case, and we can't really go into the depth. So it'll be good to look into whatever we are discussing at length. And as Ogni said, there are lots of ways of doing the right thing, and we'll see how things go. And then if we have any input to share, if we have got anything to share, we will obviously go along with that. Okay, I think we can begin now.
So I request Dr. Shreya to start your case presentations. So please share your screen.
Good evening, everyone. My case is a case of myocarditis.
Yeah, please go ahead.
Our patient was a 12-year-old male child with symptoms of fever for 10 days, with generalized swelling of the body for 8 days, with respiratory distress for 3 days. The child also complained of pain in chest and abdominal region during the same duration, and there was also increasing in drowsiness since the last 1 day. The patient also experienced 1 episode of convulsion on the day of admission, and hence the parents brought him to the emergency department. The child on admission was maintained for airway with proper positioning and suctioning. On examination, we found out that the child was tachypneic with respiratory rate of around 78 per minute. There was significant subcostal and intercostal retractions. The saturation was 68% at room air, with bilateral crepitations on auscultation. We started the patient on moist oxygen inhalation with NRBM at 6 liters per minute, and the saturation increased to 90% with moist oxygen inhalation with NRBM. Then on coming to CVS examination, we found out that the child also has tachycardia of around more than 160 beats per minute. The pulse volume was feeble. The BP was 70/40, which was less than 5th percentile for the patient. The CRT was prolonged, that was more than 3 seconds. The extremities were cold, and there was also tender hepatomegaly on palpation. So on suspecting shock, we started the child on IV bolus with NS at 20 ml per kg and started the patient on maintenance fluid with 100% TFI. Since the child had convulsions and inability to feed, we started the child on injection levetiracetam at 20 milligram per kg per day after a loading dose of injection levetiracetam. There was also fever, so we started the child on injection paracetamol and IV antibiotics. So till now, our differentials were pneumonia with septic shock or dengue shock syndrome, scrub typhus, or cardiogenic shock. After the initial management, we saw that the patient showed worsening of symptoms with increased chest wall retractions, increase in tachypnea, increase in bilateral crepitations. There was feeble pulse volume, and the cold, clammy extremities had increased, and there was also increase in liver splat. So we shifted the child to PICU. The ABG at that time showed a pH of 7.11, PCO2 was 35, PO2 was 69, bicarb was 13, base excess was -16, sodium, potassium, and calcium values were normal, but the lactate was 9. So our initial conclusion was that the child was not tolerating IV fluids, because after the installment of IV fluids, the symptoms had worsened. So after the child was shifted to PICU, at first we gave the child a trial of NIV. The child was kept on NIV PAS mode with PEEP of 8, PIP of 15, and yes, sir.
Can you just hold on? We've gone quite a bit. Can you just go back to the blood gas?
Sir.
Yeah, and tell me from that blood gas, what is it telling you?
So since there was a pH of 7.11 with bicarbonate of 13, sir, at first we thought that it was metabolic acidosis. PCO2 was 35. Yes, sir. PCO2 was 35 and PO2 was 69, which was also less for the patient, and the lactate was 9. So there was lactic acidosis as well as metabolic acidosis in this patient. And probably there was PCO2 washout in this patient.
Right. So where is the problem?
So there was metabolic acidosis, and probably the child was hyperventilating, due to which there was PCO2 washout in this patient, and there was not significant oxygenation.
So two things. One is there is metabolic acidosis, absolutely, and your lactate is also pretty high, isn't it? So most likely we are not perfusing very well.
Yes.
No. Yeah,
yes,
that is one thing. And the other thing is, if your pH is 7.11, okay, then what would you like your PCO2 to be?
Sir, according to will
it be 35 or will it be more, or ideally, if your pH is 7.11, your PCO2 should be 35 or a bit more or a bit less?
So that is asking
sir,
about the
so it should have been a little bit more. Yes,
no.
sir.
So
should have been a little bit
about if there is a normal
can you also open your video? It is
sir,
better
since
to
sir, according to that equation,
it's better to if I can see your face, it feels better. Or if there is some issue, then it's not a must, don't worry. But what I'm asking is, if your pH is 7.11, then normally, physiologically,
normally,
what would you like your PCO2 to be? 35 or more or less?
So if you have to interpret this CO2, you have to calculate the compensation. Do calculation and see if you put it in Winter's formula, what will be the PCO2? It will be around 20, but it is 35. So it is,
even if you do not know, I mean, even if you do not remember the formula, I don't remember the formula. I cannot remember the formula. I'm bad. I don't have very good memory. So I cannot really. But what I know that if you are acidotic, then you would be compensating, right? And that means your PCO2 should be less than normal at least. Nah? 35 is in the lower range of normal. So ideally, this patient should pant a bit more and blow off a bit more carbon dioxide and should bring his PCO2 even further down. It is a bit low, but ideally it should be even lower. But that is not happening. So there is possibly also a degree of respiratory failure, which may be entirely secondary to the perfusion, not necessarily the lungs are at fault. If you are perfusing if you are not perfusing well, then all your organs are going to fail. So it may be secondary to the perfusion bit, but the compensation is also not adequate, right? And most likely my perfusion is not good. Yeah.
So the interpretation of ABG would be metabolic acidosis with respiratory acidosis.
Okay.
Well, it's not really respiratory acidosis, Shweta. It's you can say with inadequate compensation, and that's
inadequate compensation.
It's not really because the brain is not working. The child has got a respiratory rate of 78, so obviously the brain is trying to compensate, but there is a mechanism for which the compensation is not happening. I'm sure we'll discuss that mechanism later. So the child is panting. The respiratory rate of 78 in a 12-year-old obviously is not normal. I mean, I don't think you can go any further. So the brain is, though the child had a convulsion and is drowsy, the brain is trying to compensate, but the compensation is not happening because there is some, I would say, mechanical problem. Yeah. So
and one more thing about the levetiracetam loading. What loading dose do you use for Levi?
Sir, 40 to 60 milligram per kg per day. I mean 40 to 60.
Yeah. I mean, what I'm trying to say is the levetiracetam loading. I have seen people using even 20, which is definitely low. More and more people are using 60, but at least 40.
60 is the recommended dose.
Yeah, 60 is the recommended dose. 20 is definitely less, and many people still use 20 as a loading dose, which is definitely low. I personally use 60. Possibly Shomenda also use 60.
Yes, yeah, I do 60 as well.
So on admission to PICU, we gave a trial of NIV, and the settings were of NIV PS mode of P of 8, PIP of 15, and FiO2 was 100%. The saturation was not maintained, so we intubated the child with ketamine and rocuronium with modified RSI. The patient was hence intubated and put on PCSIMV mode with a PEEP of 8, PIP of 15, and FiO2 of 100%. As soon as we intubated the child, we saw that there was pink profuse froth coming from ET tube. There was incremental PEEP titration was done, and final PEEP was set at 12, and SpO2 was around 97 to 100%. After that, we found out that the child also had the child still had low pulse volume.
We'll hold you there again. You have said something very, very important. You have said something golden. And that is incremental PEEP titration. You have said that, yeah? Incremental PEEP titration was done. And finally, you have decided that for this particular kid, 12 PEEP is the best PEEP. Yes? That is what you mean by incremental PEEP titration? Right. Tell me a little bit more about that for the audience, possibly, that how do you decide that for this kid, although I have started at 8, but 8 is not good enough, for this kid, 12 is the right number. How did you decide that process? Possibly it is one very important learning thing, especially for the audience.
Yes.
How did you do that?
So optimization of PEEP is the point at which there will be maximum oxygenation. Along with there will also not be over distension of the alveoli, and it will also prevent the collapse of the alveoli. So incremental PEEP titration was done, and we saw whether the lungs have been oxygenated properly.
Bedside procedure.
Yes,
what is the process?
Yes.
How do you increase the PEEP?
So we see, Yes, sir. So we increase the PEEP with a pressure with by 2 centimeters of water at each time, and then we see whether the lung compliance is increasing or not. After that, we assess the
How
child
do you
after for
know
5 to
whether
10
the
minutes.
lung compliance is increasing or not?
So we see the plateau pressure and the plateau pressure, and if the plateau pressure minus PEEP is the driving pressure, and if that is less than 15, then we can see like if it's less than 15, it means that the lung compliance is increasing, and if it's more than 15, it means that the lung compliance is decreasing. So
Other
at
thing
first,
you see,
so we see
other things, then
Sorry,
other
what is your
parameters.
mode? What is your mode? You have said
so other things.
SIMB, PC. You are PC mode. Nah, you are in PC mode, right?
So we see
The
the
Yes.
same
tidal
pressure, what
volume.
will be more?
So we see that in pressure control mode, we see whether the tidal volume is increasing or not. If the tidal volume is 6 to 8, like we
Right.
try to keep it at 6 to 8 ml per kg. So by increasing the PEEP, we see whether the tidal volume is reaching or not. If the tidal volume is increasing, it means that the lung compliance, which means that the recruitment of the alveoli is sufficient, and this is the PEEP which the patient will tolerate. And after a certain point, if on increasing the PEEP, if the tidal volume is decreasing, it means that the lung compliance is again decreasing. So that is the PEEP which we select at which the tidal volume is achieved.
Right. I have one more question. That is what you have said is PIP of 15. Was your PIP 15 or was your PC above PIP 15?
So
Sure.
PIP was
In your machine, do you set a PIP or do you set a PC above PIP?
the PIP was set in our machine.
Right.
PCR.
So if it is PIP, suppose if it is PIP, so suppose you started with a PIP of 8 and your PIP of 15, right? And now
Yes, sir.
you are titrating your PEP. So you have gone up on your PEP from 8 to 10, right? What do you do to your PIP? Do you also change your PIP or you leave it at 15?
So we also increase the
No.
so we so PIP is the resistance and the compliance. So we also increase the PIP.
You also increase the PIP. By what?
So PIP is also increased by so by 2 or
So
3.
you have increased your PWP from 8 to 10, and you will also increase your. Generally, most of us use Mackay, and in Mackay,
Yes, we have two types of ventilators, sir.
yeah,
One Mackay ventilator with that we use delta P, and in delta P we don't touch the delta P button. But there are
exactly.
other set of ventilator where we set PIP. In that case, we have to increase the PIP. So
Exactly.
he's getting confused with these two type of ventilator. We have both type of ventilator.
Exactly. So it is very important when you are using PEEP titration to, if you are using Mackay where you have PC above PEEP, then, as you increase your PEEP from 8 to 10, your PIP automatically increases to 17 because your PC above PEEP is, your driving pressure is sort of fixed. But if you have a ventilator where you separately set PEEP and PIP, there, if you are doing a PEEP titration, as you go up on your PEEP from by 2, you also increase your PIP also by 2. And then only you will be giving the same driving pressure. And then you need to check whether your tidal volume is increasing or remains static or is coming down, right? And if it is increasing with the same driving pressure, as you have increased your PEP, your tidal volume has gone up, then you know you are doing something good. So this lung loves that higher PEP. So you keep doing that, right?
Yes, sir.
Yeah. And then you keep doing that until so 10, you have gone up to 10 and your tidal volume has increased. Then what you have done? You have gone up to 12.
Yes, sir. Yes, sir.
And yes. And then why you have not gone up to 14?
So then the tidal volume was again decreasing. So
Fantastic. Fantastic. So that is the thing. So, so basically you need to keep up going on your PWP, keeping your PC above PIP same, and at a point where you see your tidal volume is going down, that is when you know you are overstretching the lungs. So you need to back off a little bit and set there. That is how we do it. Yeah.
Yes, sir.
Thank you. Carry on.
At PICU, we found that the
I
pulse
just wanted
volume
to
was
check.
low. The BP
Hello,
was 70 by 40. Yes, sir.
Yes, I
Yes,
just
sir.
want to check, when you put the child on NIV, what did you think your chance of success was with NIV in this situation?
So we thought that a trial of NIV can be given because in like if it's a cardiac cause or if it's a respiratory cause, then at first if we like there has been a good outcome with NIV, and it can also prevent intubation, which is an invasive procedure. So at first we wanted to give a trial of NIV and see whether the child was responding or not.
Okay, so you thought there was a good chance of succeeding with NIV?
So, sir, that in that case, that child was in a cardiac failure. But initially, it is. I wanted to highlight this thing also because this type of child came in emergency all the time. It is very difficult to differentiate from this from septic shock because they have abdominal pain, chest cramp, their chest cramps in the chest, fever, and everything looks like septic shock. And this child was got some bolus, which was not desirable for this child, and child developed a acute pulmonary edema, most probably not tolerating that fluid. So we have given a trial of NIV so that we can institute other options, like if we were able to stabilize the child quickly, then we could have drained out that fluid. So we have given this child a trial of NIV, but there was some contamination, like that child had a convulsion before, prior to that, and sensorium was borderline. So we have given a trial of just for an hour, and child was not tolerating. We have shifted this child to
No,
existing.
I'm not contesting whether you should try or not. I'm just trying to get at the point. What did you think the chance of success was? Because intubation is a procedure that will take some time to get ready with. So
Yes.
we often put children in NIV just trying to buy some time. By the time we get enough expertise, enough, sometimes getting medicine can be an issue as well. So in that scenario, I know I'm going to intubate, but I'm trying to buy some time by putting the child on NIV. Do you think this child will be salvaged on NIV? That's what I'm getting at.
No. This child most probably would need invasive ventilation.
Okay.
And why is that so? Why is the chance of success very low?
Because child was hemodynamically unstable.
Exactly.
That was a temporary that was a relative contraindication for NIV, and child orientation was not that, though child was not unconscious but had a convulsion, most probably hypoxic convulsion, but both are contraindication for relative contraindication for NIV.
Absolutely.
So we gone
absolutely
against these both odds.
true.
Okay. Yeah, go ahead. Shreya, go ahead.
The child also had low pulse volume with BP of 70 by 40, which was less than 5th percentile for the child. There was tender hepatomegaly and cold extremities. So we started the child on non-adrenaline at 0.2 microgram per kg per minute. Catheterization was done to 10 microgram per kg per minute. After 6 hours of intubation, this was the ABG which we received with a pH of 7.38, PCO2 was 52, PO2 was 98, bicarbonate was 20, base excess was -8, sodium, potassium, and calcium levels were normal, and the lactate had decreased to 5. Then we proceeded with POCUS, and we saw that there was bilateral B lines present in lung fields. There was global left ventricular hypokinesia with ejection fraction of 20%. IVC was distended but non-collapsible. And this was a chest X-ray which we obtained for that patient. So our conclusion was the child was in heart failure. The ejection fraction was by POCUS was 20%. So after starting the child on noradrenaline, the BP improved to 50th percentile. Urine output for the last 1 hour was 0.8 ml per kg per hour. So we started the child on injection milrinone at 0.3 microgram per kg per minute. The patient tolerated milrinone and the BP did not fall even after 4 hours. The pulse volume was moderate, extremities were warm, but the urine output was 0.6 ml per kg per hour. So on the background of volume overload and we started injection Lasix infusion at 1 milligram per kg per hour.
1
We
milligram.
saw that the PP stabilized to more than 50th percentile. The pink
Was
froth,
it
which
1
was coming out
milligram
of
or
the
was
ET tube,
it
had also
0.1?
0.1. 0.1.
0.1 milligram. Yes, sir, 0.1 milligram per kg per hour. So
It's 0.1. Yeah. Okay.
yes,
Yeah.
so it was 0.1 milligram per kg per hour. The BP had stabilized to more than 50th percentile. The pink froth, which was coming out of the ET tube, had also decreased. The heart rate had come down, which the patient had previously presented with tachycardia. USG lung showed decrease in B lines, and the ejection fraction on echocardiography was also 25%. This was the ECG which we
I'm
obtained
going
for
to
the patient.
interrupt for another question I have, Shreya. Did the child have any cardiac surgery in the past?
No, sir, the child did not have any cardiac problems, or there was no history of any cardiac problem in this child in the past.
So why did the child have sternal wires? Go back to the X-ray. The child has
Yes, sir.
sternal wires put in. Can you see those
And-
rings?
And no ET tube. So it's yes.
So is it an X-ray from a different
No.
patient?
Yeah. No ET
Yeah,
tube.
there is no ET tube either. Yes.
Yes, sir.
It's a different X-ray.
Okay. Okay. Stay with the ECG. Stay with the ECG.
Yes, sir.
So what do you see in the ECG?
So there was ST segment depression with inversion of T waves. There was also ventricular ectopics in this X-ray with.
Would you like to qualify any further than ventricular ectopics?
So,
What's happening here?
so there was ST segment depression with T wave inversion.
So you can see, I can see the one. So if you look at lead 2, the top panel, you can see the QRS complex with
Yes, sir.
T inversion and ST segment depression. And what is the one in between those two? There's another QRS complex in between.
Yes, sir.
So what's happening there? The big ones don't have any P. I can't see any discernible P before that. The other ones, the smaller ones, possibly has a P before them, inverted, but I think there is a P there. So what's happening there?
So there was
No. Go up.
No, if you go to the top panel,
Go up.
top panel, the lead 2, the one marked as lead 2. Yeah, put your cursor above lead 2.
yes, sir. This is
That
lead
is
two.
lead 3. That is lead 3.
So
Sorry,
this-
Hello?
sorry, lead 1. Sorry, lead 1.
Yes, sir.
That one. Yeah. So if you see the big one,
Yes,
that's
sir.
a complex. QR is going up and T
Yes, sir.
going down and possibly ST depression. Yeah. And then
Yes,
you
sir.
see an inverted P wave, then a QRS complex.
Yes, sir.
And the same thing is repeating. So I can see 1, 2, 3, 4, 5, and the child was then possibly moving a bit. And then again, that pattern repeats. What is that? Which one is normal amongst those two? Which one is normal and which one is abnormal, do you think? Among those complexes, the two complexes, you can see
Most
one.
probably, the second one was junctional rhythm, and first one is that there was no junction. T wave is inverted. That is abnormal T wave also.
I don't think so. Which one is normal, do you think, Shreya? among these two? One with QRS reflection above the line and one QRS reflection below the line. Which one is normal?
So QRS deflection above the line.
So which one did you think were ventricular ectopics?
So the one which was going below the line was the ventricular ectopics.
But that one has a P before it, isn't it? See, consistently they have a P.
Yeah.
Inverted, but there
Yeah.
is one. So I think this is ventricular bigeminy. Okay. So the normal one is actually the one with P and small QRS. And
Yes,
the
that
one
was it.
after that is the ventricular ectopic, and it's coming in pairs. So I think the child has got ventricular bigeminy, at least this ECG. I don't know if this is the ECG from that child, but
No, it is from
this
the
ECG, okay, this ECG shows ventricular bigeminy. So I'll be scared to death if I see this in that background. Can you see two different type of complexes? The bigger ones are actually coming from ventricle. It typically looks like RVOT, ventricular ectopic. That's what they look like. And the one before that or after that, the smaller one, that they are possibly sinus or somewhere near sinus. Okay. Go ahead.
A formal echocardiography was done, which showed a left ventricular ejection fraction of 28%. LALV was dilated. There was moderate AR with mild MR. And also we saw there were dilated coronaries with the LAD of Z-score of 2.06, which showed mild dilatation of LAD. There was mild dilatation of LMCA also with Z-score of 2.23 and mild and dilatation of RCA with a Z-score of 2.02. We then went for investigations. So the routine blood count was sent. CRP, procal, and other inflammatory markers were also sent. And we saw that the procal was 3.7 nanogram per ml. And there was increased pro-BNP levels of more than 35,000. All the infectious parameters were also sent, and MP, MPD, dengue, IgM, and scrub typhus IgM were all negative. Blood culture was negative, and urine REME-CS was also negative. So till now, our provisional diagnosis was myocarditis presenting with congestive cardiac failure and cardiogenic shock with pulmonary edema, probably due to viral myocarditis or toxic myocarditis, MIAC, or incomplete Kawasaki. So since the patient presented with heart failure, so the major causes of this heart failure could have been viral myocarditis. But since viruses are very difficult to isolate, so we could not possibly rule out the possibility of viral myocarditis in this patient. Toxic myocarditis was also a common finding, but blood culture CS was negative. MIAC, since we are living in a post-COVID era, so MIAC is also a very important differential in this case, and it's a multisystemic disease with coronary involvement, so which our patient has presented with. Incomplete Kawasaki can also be considered in this patient. And incomplete Kawasaki is mostly seen in small children and adolescents. So our patient was falling in this age group. But other criteria of Kawasaki disease, of incomplete Kawasaki disease, was not being fulfilled. But since the echocardiographic findings were there, so we could also consider incomplete Kawasaki in this patient. So our provisional diagnosis of viral myocarditis was kept, and we started the child on IVIG at 2 gram per kg. And to avoid fluid overload, we started the child on 400 milligram per kg per day of IVIG. COVID antibody was sent on day 3, and the report was positive. So our diagnosis was MIAC shock syndrome presenting with myocarditis. The criteria of myocarditis is if a child or adolescent aged between 0 to 19 years of age has fever for more than 3 days, and any two of the following criteria, like rash or bilateral purulent conjunctivitis, hypotension or shock, and features of myocardial dysfunction, or evidence of coagulopathy or acute gastrointestinal problems, and elevated markers of inflammation like ESR, CRP, or procal, and no other obvious microbial cause of inflammation, including bacterial sepsis, and if the child had positive RT-PCR or COVID-19 testing, then we can classify the child as MIAC. Our child was a 12-year-old male child with fever for 10 days, presenting with hypotension and shock, with myocardial dysfunction, with elevated CRP and procal levels. There was no evidence of bacterial sepsis, and the COVID antibody came back to be positive. So we diagnosed the child as MISC following this criteria, and hence the child was started on injection methylprednisolone at 10 milligram per kg per day. Tablet aspirin was also started at antiplatelet dose of 2 to 3 milligram per kg per day. The child was kept on a fluid-restricted regimen with 60% TFI, inotropes, and injection Lasix at 0.1 milligram per kg per hour. There was strict intake output monitoring, and on the first day, the total intake was 480 ml, output was 580 ml, so the balance was around minus 100 ml. After 24 hours with stable vitals, we started the child on enteral feeding, and within 48 hours, full enteral nutrition was established. Daily monitoring was done by focus. To check for IVC distension, collapsibility, myocardial contractility, and pulmonary edema. On day 3, we started decreasing the ventilator settings, and the saturation was 95 to 99% with FiO2 of 60%, PEEP of 10, PIP of 18, and del P of 8. Gradually, we came down on the PEEP, and ejection fraction also improved to 40%. BP was more than 50th percentile. Noradrenaline was slowly tapered off, and Lasix infusion was omitted, and intermittent Lasix was given at 2 milligram per kg per day. This was the ABG which we found. After the patient was in PICU, and we saw that there was metabolic alkalosis with 7.48 of pH, and potassium was also had also come down at 2.7. So we started the child on potassium supplementation. This was probably due to the prolonged use of Lasix in this patient. So we started omitting the Lasix infusion, and intermittent Lasix at 2 milligram per kg per day was started.
What do you think about the calcium level?
So the calcium had also come down at 0.8, which means that the due to the Lasix use, the calcium was also going out.
Did you do anything about it?
So yes, sir, calcium supplementation was also given. We gave an acute correction, and then we started the child on syrup calcium.
Okay.
So on day 4,
why Soumendra has asked that question? Why? I mean, in a kid whose heart is not pumping very well, who is needing maybe a little bit of inotrop, their calcium is almost acts like an inotrop. I mean, you cannot let their calcium drop. Especially ICAL should be around 1. It's important.
Well, if you're using inotrop, the recommendation is that you keep your annualized calcium above 1.15, because calcium is either the second messenger, or if you look at milrinone and levosimendan and things like that, they're calcium sensitizer or enhancer in a sense. So you need calcium, otherwise none of your inotropes will work. Your catecholamines work to calcium only. So if your calcium is low, it doesn't matter how much inotrop you're giving, it's not going to work.
Yes.
That's the point. Yeah, that's the point. Yeah, carry on.
Yes. So on day 4, the patient was put on NIV, and milrinone was slowly tapered off and omitted. On day 5, NIV was also omitted, and the child was put on nasal cannula. The child should improve ejection fraction at 45 to 50 or 45 to 50%. On day 6, milrinone was totally omitted, and on day 7, the child was shifted out of PICU. This was the course of stay of the child in PICU. And on follow-up, the patient showed improvement in vital parameters. The pulse volume was normal. There was no sign of respiratory distress. The saturation was 100% at room air. Urine output was adequate, and there was no organomegaly. Bilateral chest was clear. After 2 weeks of repeat echo, these were the coronary findings, and the ejection fraction had improved to 53%. There was no left ventricular dysfunction at present, and the pro-BNP and the pro-BNP level, which was initially more than 35,000, had also come down to 2,534. So the child showed overall improvement. And now the child is being followed up. And since in this patient, we could not totally rule out the possibility of incomplete Kawasaki, but since there was no other way of diagnosing incomplete Kawasaki in this patient, so along with MISC, we had also kept a diagnosis of incomplete Kawasaki in this patient. Thank you.
Thank you, Shreya. Very well done. And Shatrabrata as well. I just wanted you to go back to the first slide. I can't remember whether this was first or second slide. No, the one after this. Yeah, okay. So it says that you have put the child on oxygen with NRBM with a flow of 6 liters per minute. How do you decide this? How much flow you should put somebody on NRBM?
Sir, through NRBM, we can deliver an oxygen of 8 to 10 liters per minute of oxygen. So in this child, we had initially given the child at 6 liters per minute of oxygen. So the child had a saturation of 90%.
What is the principle of NRBM? How does NRBM work, and how is it different from a simple mask?
Sir, in NRBM, since it's a non-rebreathing mask, so
Yeah.
like 100% of the oxygen which is there in the reservoir is goes into the person who is who is breathing through the NRBM mask. And in face mask or nasal cannula,
so it stands for non-rebreathing
breathing
mask, isn't it? So what does this
Yes.
non-rebreathing word mean? Shatrabrata, your mic is off if you're saying something. Shatrabrata, your mic is off if you're saying something.
Shreya, sir is asking about how the mechanism of the NRBM mask, how it works, and how do you determine the flow. You have written that 6 liter flow, which is quite low than we prefer usually start. So sir is asking this question because reservoir should function. Otherwise, the source of oxygen that provided by the reservoir will not work, and child will rebreathe it. So reservoir is inflated or not, that has to be seen by you.
What will be your flow if you are using a simple mask? If you are using a simple mask, then what sort of oxygen flow will you use?
So if it's a normal mask, then we can use a flow of 3 to 4 liters per minute of oxygen.
No, 5 liter, more than 5 liter. At least more than 5 liter, otherwise child will rebreathe.
So 5 to 6 liters.
8 to 10 liter flow.
So as Shatrabrata was saying, it is important that the bag attached to your NRBM mask, so or reservoir attached to the NRBM mask should always remain inflated. So it should not be drained out completely. If it's draining out completely, then the child will breathe in from atmosphere or from his own CO2. So you need to ensure that there is enough flow. 6 liters sounds very low for a 12-year-old. So normally you would put at least 15 for somebody nearly adult. Okay. Do you understand the concept of low flow and high flow devices for oxygen?
Low.
So what are the devices, oxygen delivery devices? We can divide it two groups, low flow and high flow. Okay. So sir is asking about which are the low flow and how you determine which one is low flow and which one is high flow. Okay.
The low flow oxygen devices can be through nasal cannula or face mask. These are the low flow devices, and high flow devices can be NRBM, NRBM mask.
Then you have any device in your institute that can provide high flow?
Yes, sir. High flow. So the high flow nasal cannula, which can the heated humidified high flow nasal cannula can be used, which is also a high flow device.
So which one is called low flow? Why it is low flow and why it is high flow?
So low flow because we cannot increase the oxygen delivery to more than like in nasal cannula, we can use deliver the oxygen of 2 to 3 liters per minute, or 3 to 4 liters of per minute. And through face mask, we can deliver oxygen of 5 to 6 liters per minute. So these are the low flow devices.
So because you are not overcoming the normal flow, airflow during inspiration. So your flow rate is less than the normal inspiratory flow rate. So these are the low flow device. You cannot give fixed oxygen to this low flow devices.
So that's the important concept, that it's nothing to do with liter. So if I give 2 liters per minute to a preterm baby, that might be a high flow device. Okay, so liter is not important. Importantly, if I can deliver the peak inspiratory flow with my oxygen delivery device, then that's a high flow device. So if I'm delivering more than the peak inspiratory flow, then that's a high flow device. If you are providing anything less than that, that will be a low flow. NRBM is not necessarily a high flow oxygen delivery system. Go back to the next couple of slides. I just wanted to know, you chose your first vasoactive as noradrenaline. I just wanted to know why did you choose noradrenaline?
So at first we suspected that this patient may be in septic shock. And in septic shock, the initial inotrope of choice is noradrenaline. And even if the child was in cardiogenic shock, then in cardiogenic shock, there is vasodilatation. And in vasodilatation,
sorry,
noradrenaline
I'm going to stop you there. You said the choice of vasoactive in septic shock is noradrenaline. What do you have any evidence to support that?
So, sir,
Yeah, what is written in surviving sepsis guideline?
Sir,
What does it say?
Sir, in surviving sepsis guidelines, sir, we can use adrenaline as well as noradrenaline. And in adrenaline, it has been shown that there is improvement in myocardial oxygen, like there is improvement in the urine output, as well as there is the myocardial oxygen demand is less if noradrenaline has been used. So noradrenaline was chosen as the first agent which can be used in place of adrenaline.
It is not very clear that in surveillance guideline, noradrenaline has been given first priority. Till now, as per textbook, adrenaline is the first line drug. But surveillance guideline has told that there is clearly no clear evidence that suggests that which one noradrenaline is inferior to adrenaline, and adult literature suggests adrenaline is better than noradrenaline. Okay, so if the child is more age is more towards adolescent, we can prefer to go along the adult guideline. So we have started this noradrenaline.
Shatrupati, you just said the opposite thing. So yeah, the adult literature shows noradrenaline may be better. Okay, there is not huge amount of or very strong evidence. Adult literature shows that noradrenaline may be better, but there is no evidence whatsoever in pediatrics to choose one over the other. But given now that you know this child had myocarditis with decreased LV function, compromised LV function, if you know that beforehand, would you have changed your vasoactive to begin with?
Shomenda, if this child is having myocarditis is more arrhythmogenic, and child already had ECG of, we have seen that later, and in running ECG, we have also seen there was ectopics are coming. So for that reason, we have chosen noradrenaline in this child.
Yeah, but if you have got an ejection fraction of 20%, putting 0.2 microgram per kg per minute of noradrenaline.
Adrenaline may help in that part. Adrenaline is inotropic and noradrenaline didn't have any action on the heart. It's only peripherally acting.
What would be your near ideal vasoactive in this situation?
So these are not ideal at all. There is no ideal thing at this stage, I'd say, because the ideal thing would be that will decrease the myocardial oxygen demand, that will increase the inotropic action, that will decrease the afterload. But this is like milrinone. Milrinone starting from first hand in this child is quite difficult because the child may collapse due to that child DP is not that hard, that's not satisfactory. Child circulation is already collapsed. So in this stage, if we start first hand milrinone, the child may collapse. So we have started this noradrenaline first, and then we have shifted to milrinone.
You have used dobutamine in a relatively high
Yes,
dose, I would
that
say
is
10 mics. Is dobutamine actually helpful?
dobutamine is it is like when we are working in these situations, like it doesn't make the BP fall too much, and it also had some action on the heart. So it is quite, it feels safe to work with. But it
what would be
increases
your
markers in the mind, it causes tachycardia.
yeah?
I agree with.
So I was going to say the child had a heart rate of 160 or something like
Yeah,
that.
yeah, it causes tachycardia.
So I think I'll be rather worried of using dobutamine in this situation.
Yes.
Go to the next slide.
Let me ask Soumendra.
Yeah.
What would you use in terms of inotrops? In terms of inotrops, I mean, this is what Soumendra has raised is something that we talk that crops up almost, that crops up all the time, and we keep discussing it, and the very fact that we keep discussing it tells us that it is difficult. If it was easy, then we would not have so much discussion on this topic. That very fact tells us that it is tricky, it is difficult. So let us find out what Soumendra would use, and with the results.
Yes. So what I would do is, if I suspect myocarditis or low LV ejection fraction, then things that I will start, irrespective of blood pressure, is a low dose low dose adrenaline and milrinone. And I'll start this before I go on to intubate this child. So that's the other thing I was going to come to. I would not give any sedative or even ketamine to this child until I have got some vasoactives on board. These children tend to be very difficult. So we think noradrenaline will not make them more hemodynamically unstable, but moment child goes to sleep, you take away their catecholamine drive and their intrinsic catecholamine levels go down. And that can be enough to just make the heart not work anymore. So I would give some low dose adrenaline. I will use
when you say low dose milrinone, what sort of dose you are talking about?
No, not low dose milrinone. I'll give low dose adrenaline, 0.05 microgram per kg per minute. I'll start milrinone as normal dose, 0.5 microgram per kg per minute, but I would not give the loading dose. The thing with milrinone is that people are very scared of it, but milrinone doesn't work instantaneously. It takes some time. So that's one of the disadvantage or advantage of milrinone. It will take at least 3 to 4 hours to start working unless you give the loading dose. So I wouldn't be too worried about blood pressure falling, things like that. If blood pressure falls with a very wide pulse pressure, I have got noradrenaline, which works instantaneously. I can add that later on. So I will go with low dose adrenaline, as in around 0.05 microgram per kg per minute, along with milrinone, before I intubate this child. And then I'll titrate. The myocardial ischemia is the major reason for their arrhythmia. Myocarditis per se can cause arrhythmia, but myocardial ischemia is the other big reason. So if I can improve myocardial perfusion, my ischemia may go, my ventricular ectopics may actually go away. But that was a very dangerous rhythm to have, the ventricular bigeminal. And the last question I have, sorry.
Yes.
I was just going to ask one last question.
Dr. Mehul and Dr. Omnishekhar Saha. In fact, we are running short of time. There are a few questions over there. If you please answer those. So one thing is that before asking the question, I will request all the PGTs, the Sandhya, what is the intention of Sandhya Pathshala? This is the PG activity. So whatever you have presented, just like the case presentation. So actually there was no chief complaint, no present illness, no past illness. I know this is not the forum. In fact, we want them to meticulously write down the history properly. But here it is missing. I'm not criticizing you, but be careful when you present a case in which platform you are answering. Another thing is that whenever you present, never put any other X-ray. What Dr. Mew has pointed out, there are the standard clips. So it's better. Yeah, I don't have that X-ray. It's better not to give it. because it is in future you will face a lot of problem for that. And there are some questions now. So Dr. Basudev Patra asked, any one of the experts can answer. We frequently find empirical antibiotics started before workout. I mean, working up the patient. Is there any protocol regarding the type of antibiotics?
Okay,
So,
yes,
Dr.
surviving sepsis recommends that you give antibiotic. If you think this is septic shock, then you should give antibiotic, a broad spectrum antibiotic, within as soon as possible, but within 1 hour. There's a bit of controversy about timing, but I think we should stick to antibiotic as soon as possible, and definitely within the first hour. What antibiotic you choose, a broad spectrum antibiotic that you like. I don't think there is any particular guidance about that. And workout is not really needed. Your suspicion is enough. If you're suspecting, then you can give. If you can take a blood culture, that's fantastic. If you can't, because you can't take a blood culture, that should not delay your antibiotic administration. So that should be given as soon as possible. If you ask me, my personal choice, I'll give ceftriaxone.
Thank you.
One thing, maybe, Shopon, the one thing we need to tell, we talk all the time that don't give antibiotics willy-nilly, don't give it antibiotic indiscriminately. And that is a very, very important point. Absolutely. That is, I'm not taking anything away from that. That approach is very much needed, and you are still, abusing antibiotics. That is very much true. But when it comes to intensive care, and when it comes to a patient who is presenting to you with shock, and you are just suspecting septic shock, antibiotic is paramount. Antibiotic is very, very important. If your first antibiotic does not hit it, then half the war is lost. So in a patient of septic shock, the approach is reverse. You have to give an effective broad spectrum antibiotic as soon as you can. If it is not a septic shock, you can always stop it. So the approach is reverse.
Thank you, Agni. You have got another question that Ajay Raghav Joshi has asked. Kindly elaborate how to do the calibrated PWP PIP setting once again, as there were a lot of disturbance in the audio in between. So, Agni, if you can please, not elaborately, but briefly, how to calibrate.
Look, it is again a lot of discussion happens on this. I will try to give you a very short and simple answer, which is easy to follow. Right? I am sort of assuming that you are on pressure control. You are on whatever mode, but you are on pressure control ventilation. And if you are on pressure control ventilation, ideally when you are doing it, your patient should not be doing a lot of stuff. Your patient should be ideally be paralyzed, or at least the patient should not do a lot of stuff on his own. He should not, breathe on his own a lot. Ideally, they should be paralyzed. And there, what you want to figure out is how much PEEP is optimal for this patient. And this is happening in a patient who has got a tight lung, not an obstructed lung. And a tight lung, so in a ARDS sort of scenario, and your saturation is not good. And so what you do is you start with whatever PEEP you have got, which is a bit lowish. So you are starting with a lowish PEEP, and you keep your FiO2 and your PC above PEEP. It is very important. Your PC above PEEP should be constant. So if you are using a ventilator where you have got PEEP and PIP, there, as you increase the PEEP, you correspondingly also need to increase the PIP. If you are using a ventilator where you have got PEEP and PC above PEEP, then you keep your PC above PEEP constant, right? And you start with a lowish PEEP, and then you go up on your PEEP by 2. And then ideally you should sit there for at least about 1 to 2 minutes, and then check what is your tidal volume and compare it with the tidal volume that you are getting previously. And if you see that your tidal volume has gone up as you have increased your PEP, that should not happen ideally. Ideally, that should not happen. So if that is happening, that means you're in the right track. So you keep going up again by another 2 and again check your tidal volume. Has your tidal volume gone further up? If it has gone further up, you keep going up. You keep going up until you reach a stage where either your tidal volume plateaus or actually it starts dropping down. Once it starts plateauing, or especially if it is falling down, then that is you have reached the phase of over distension. Then you need to come down to that level of PEEP where you have got your maximum tidal volume. Oftentimes, you can also see a response on your saturation. As you go up on your PEEP, you can also see your saturation improving with the same amount of FiO. Hope that explains it.
Just
Thank
wanted
you,
to quickly
Dr.
add to this, Ogni, that in this patient, the way PEEP helped is not with lung recruitment, with a different mechanism. So in this patient, PEEP possibly helped with reducing LV afterload, which is the other utility of PEEP. So this child was in heart failure with a low ejection fraction. And in this situation, mechanical ventilation, positive pressure ventilation will help by reducing LV afterload and also taking out the work of breathing. So in this situation, recruitment is not what we are using the PEEP for. We are using the PEEP to support the LV. So in this patient, I probably would not go for PEEP titration. I'll start with a high PEEP, 14 or 16, something like that. I'll go even higher if I've got a ejection fraction of 20%.
What Shomendas is saying is absolutely right. What I have just told you is a general is a general statement for PEEP titration where you use PEEP titration. And that's why I've also said you use it for a tight lung ARDS scenario. You don't, it is not for myocardial shock scenario at all. Yes. I have given you a general overview of PEEP titration and when. Yeah.
Thank you, Dr. Meur and Dr. Shekhar Saha. Now we'll move on to our next case. And before that, I want to thank Dr. Shreya Halda for our elaborate presentation. So, Shreya, please stop sharing. Stop sharing your screen. Can you please stop sharing? Yeah. Now we'll next case will be presented by Dr. Bhaskar Banerjee. So, Bhaskar, please start your case. In slideshow.
Hello.
In slideshow mode. Yeah. Fantastic. You are audible and you are visible also.
Okay. Thank you. So myself, Dr. Bhaskar Banerjee. I'm working as an RMO in pediatric cardiology department at Birla Heart Research Center. So here is a case of El Relato of recurrent fever. El Relato is a Spanish word that means a story of a recurrent fever. So we have a patient, 2 years old, female girl child, Lalmi Muani Kiamte. She's from Mizoram, presented to us with intermittent fever for last 6 months and respiratory difficulty for last 5 days. The patient was diagnosed with Down syndrome at birth and developed on and off fever for last 6 months, which was intermittent and low grade in nature. Suspected infective endocarditis with vegetation, received treatment at local hospital. But the patient developed respiratory difficulty, which progressively increased and referred to our hospital for further management and diagnostic work. On taking further history, there is a past history of the patient was apparently when up to 3 months of age, then developed erythematous rash all over her body along with recurrent fever, which was diagnosed as a case of recurrent hyperinflammatory syndrome and was put on treatment and medication, which received up to November 2022. But after stopping the medication, the patient again developed fever. So they were referred to the local hospital where they have done echocardiography and shows that there is a small VSD. On this finding, they were suspected. There is vegetation and infective endocarditis case. So they have started the treatment, but there is no improvement. So they referred to us. There was no family history of similar illness. Immunization was as per date of national immunization schedule, there was global developmental delay. The birth history was that the baby was delivered by normal vaginal delivery with birth weight of 2.5 kg. First child, there was non-consecutive marriage. On clinical examination, there was airways maintained. The baby was tachypneic with respiratory rate of 60 to 66 per minute. Mild subcortical retraction, bilateral air entry was adequate. Few scattered capitation was there. Circulation wise, heart rate was 150 per minute. Capillary refill time was 2 seconds. Pulse volume was adequate. Respiratory CVS examination, both heart sound are present with an pansystolic murmur of grade 2. The disability wise, GCS was 15 by 15. She is able to move all her limb. Exposure wise, febrile, there was reticular rash over the tongue and extremity. There was absence of pallor, cyanosis icterus. There was deep edema over the dependent part. Neck vein was not engorged, neck node not enlarged, and saturation in room air was 85%, along with their hepatosplenomegaly. This is the reticular rash over his lower extremity. Treatment wise, the patient was started on high flow nasal cannula, 2 liter per
Please,
day.
Bhaskar, please stop. I'll request the main expert to intervene in the meantime before he starts the treatment.
Okay.
Anything you want to know from the history or the clinical examination? Dr. Meur and
Bhaskar, I wanted to get the timeline right. I understand that this child is now 2 years old. Is that right?
Okay, sir, I'm coming. The child was delivered and there was Down's phenotype and they were diagnosed that this is the Down syndrome baby. The baby was absolutely well up to 3 months of age. Okay. Then after at the 3 months of age, then baby developed a erythematous rash all over his body along with fever. That time the baby was receiving treatment at CMC Vellore and they have diagnosed that the patient is a case of recurrent hyperinflammatory syndrome. And they have put on the prednisolone therapy as well as some monoclonal antibody therapy, which the baby get up to last.
I'm not quite familiar with this recurrent hyperinflammatory syndrome in an infant. What's that?
How old is the child at presentation? I forgot that.
That time the child was 3 months of age when
no. When the child presented to you, I just forgot that.
I think 2 years. 2 years. I think.
Yeah, 2 years. Okay. Yeah.
2 years.
So it's a long time. So 18 months of
exactly.
No, more than that. 21 months of.
After they were receiving treatment up to November 2022.
What treatment did she receive
actually,
there?
the child was having recurrent fever from from 3 months of age, but since then, they were in the local hospital, going getting admitted, getting treatment for some viral illness, and coming back home. Then they went to, since the fever was recurring, they went to CMC Vellore, and then she was diagnosed with recurrent hyperinflammatory syndrome, and that way the treatment was continued till November 2022.
What treatment should she get there?
She was getting monoclonal antibody, ruxolitinib, interleukin-6 inhibitor actually.
Before that, she was given a lot of things, like she was given IVIG, she was given methylprednisolone, yes, and then when the cyclosporin was given, and then when it was not responding, and the child was having fever, after stopping the steroids again and again, so then they decided to give ruxolitinib.
And how did they make this diagnosis of recurrent hyperinflammatory syndrome? Did they do cytokine profile, genetics? How did they come to this diagnosis?
They have done genetics for HLH marker, but they haven't got any familial HLH gene, as well as they have done next genome sequencing. They haven't got anything, but there was a recurrent rise of ferritin at their hospital and also rise of CRP, and which responded to methylprednisolone as well as oral prednisolone. But fever was recurrent and ferritin was also recurrent. Rising of ferritin was also recurrent. So they haven't done anything proper diagnosis. They only done it's a hyperinflammatory syndrome. It's the same spectrum of disease. Something they haven't done a proper diagnosis.
What monoclonal antibody they have used?
Ruxolitinib.
Okay.
That is an IL-6 thing, yeah?
IL-6 inhibitor. Yeah.
Interleukin-6 inhibitor.
Was the IL-6 level very high?
There was no report on IL-6 level, but IL-6 was positive.
No, IL-6 will be positive in everybody, but it was that high.
We did not get any IL-6 report. So
Yes.
No
So
quantitative
but
report actually was there.
yes.
Okay. 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 So, when was this? How old was she when she went to Vellore? Do you remember?
Pardon me, sir.
How old was she? When did she go to Vellore? Shatarupa said that.
I think she
that
was
she
almost an year, one year
Okay.
when she went to Vellore. Yes.
Okay. 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 Yes. Okay. Yeah. Carry on.
So this was the reticular rash, erythematous reticular rash, which was present in his lower extremity. We have started the treatment on high flow nasal cannula 2 liter per kg with FI to 50%, targeting saturation above 90%. Started on empirical antibiotic methotrexate and vancomycin after sending septic skin and blood culture. Over the next 24 hours, there was rapid deterioration with increase in distress along with bilateral whiteout of lung. Child was intubated and ventilated in PRVC mode with P peak of 35 was there. P plat was 30, tidal volume was 6 liter per minute, FIV was 100%, peak was 15, diving pressure was 15, which was titrated as per lung protective ventilation strategy because we are suspecting the patient already developed ARDS and we have calculated the oxygen index, which was come out to be more than 18. That is in the grade of severe ARDS according to PALIS-2 guideline. In the meantime, the patient also developed 2 episodes of convulsion, where required 3 AED to control the convulsion.
Bhaskar, let me stop you there. Go back to the previous slide.
Okay.
In PRVC mode, how did you determine the peak was 35 and P plat was 30?
There was peak was 35. P peak was 35, that is showing in the ventilator.
In
No.
PRVC mode. How
Yes,
can you
Bhaskar,
see a P and P plat in PRVC mode?
No,
Or
actually,
how does
yes, Bhaskar, we wanted to know how do you calculate like peak plateau pressure and the P peak pressure? Like we can calculate, we can see the P peak, but plateau pressure, how do you, what intervention do you do to see the peak plateau pressure in the PRVC mode?
PRVC mode, how to calculate?
The plateau pressure and yes. Sir, I think yes. So we put an inspiratory hold.
You can elaborate.
Inspiratory hold show the peak light actually. From duration, how much duration I think.
Okay, so how does PRVC mode work? What does it stand
Actually,
for and
PRVC
how does
mode
it
is
actually work?
pressure regulated volume control. We used to
Okay.
set a volume and the ventilator used to give the lowest possible pressure to achieve that tidal volume.
Okay. But what is the control bit? Is it a volume control mode or a pressure control mode?
It is actually pressure control mode.
Okay. So how do you actually
both.
get a plateau pressure in a pressure control mode? How do you get a different plateau pressure in
Yeah, I mean, in the very concept of P plat comes when you have a decelerating flow, as happens when you have got a PC, when you have pressure control thing, your flow is decelerating. Then you cannot, because by the end of your inspiration, your flow is almost like zero. So if your flow is almost like zero, then how can it drop? How can your pressure drop? And if your pressure is not going to drop, then how can you have a P plat?
Unless you have gone inappropriately low inspiratory time. So let's leave that aside. If you have got an adequate inspiratory time, then how can you get a P plat in PRVC mode?
That does not happen. That does not happen. If you have got a pressure control mode, you don't get a P plat unless what Somendra has said, and that is entirely very theoretical. That almost never happens in real life.
No, that will happen. That will happen in asthma. If you put a child on PRVC mode in asthma, that will happen with a eye time of 0.8 second, 1 second.
Yeah, if your eye time is inappropriately low, but usually you should not get a P plat. I mean, you should, or let us put it this way, that your peak pressure and your P plat will be identical if you are on a PC mode.
At least in theory.
Sir, actually, I think it was initially volume control mode, and then we changed Initially, that's what he wanted to say. I think it's like.
So if you're in a volume control mode, then yeah, that is entirely possible that
Mhm.
you have
Yeah.
got a P peak and a P plat, but you can't really get this value from a PRVC mode. It's
Yeah.
yeah, it's not going to happen.
Mhm.
Okay, yeah, carry on.
Thank you. So this is a chest X-ray which is showing bilateral white outing of the lung. Then, according to this PALIS guideline, we have this how we have diagnosed the patient as a ARDS with an severity index of oxygenation. In our case, it was more than 18, so the patient was in severe grade of ARDS, and the patient is in invasive ventilation. So we have chosen oxygenation index as severity stratification. We have done some investigation like ET aspirate, which shows no growth. Also sent viral panel, which was negative, and also sent gene expert for tuberculosis, which was negative. Blood culture from central line and peripheral line peak and urine culture shows candida. Pericardial fluid analysis also done because there was also some amount of pericardial actually collection, which shows come normal, as well as gene expert was also negative in pericardial fluid. Complete blood count shows progressive decline in platelet count as well as hemoglobin level. Required component replacement. In view of past history of recurrent hyperinflammatory state, persistent fever as well as bicytopenia, and also an examination we have got hepatosplenomegaly, as well as there was multi-organ involvement. We sent investigation for inflammatory marker like serum ferritin, etc. The serum ferritin level comes out to be more than 1 lakh nanogram per ml. In the meantime, I have also told that there was a convulsion. For this, we have done CT brain, which shows in view of low platelet count, which shows hemorrhage over the right occipital lobe posteriorly, and the CRP level was 18.47 milligram per deciliter at admission. And these are the reports. The platelet count was 30,000, and the hemoglobin was 5.1, and ferritin level was more than 1 lakh. And this is the triglyceride level, that is 276, and this is fibrinogen level, that is 89 milligram. And this is the CT report, which show hyperdense non-enhancing nodular focus in the right occipital lobe posteriorly involving cortex, possibly small parenchymal hemorrhage. So what are we dealing with? We are dealing with some kind of recurrent mass, secondary HLH with severe ARDS. And this is the hemophagocytosis, lymphohistiocytosis 2004 criteria for diagnosis. If there is a known genetic defect, then there is a familial HLH or primary HLH. And if there is no gene involvement, if there is fever with splenomegaly, cytopenia more than 2 cell lineage, that is less than 9 gram per deciliter in hemoglobin, platelet less than 1 lakh per cc, and neutrophil count less than 1000. In our case, there was hemoglobin 5.1, platelet count was 30,000. And if there is hypertriglyceridemia, in our case, that was more than 265, that is 276, and hypofibrinogemia, in our case, it was 89, along with hyperferritinemia more than 500 nanogram per ml. In our case, it was more than 1 lakh. And soluble CD25 level, and that we haven't done, but we have done a bone marrow examination that have shown hemophagocytosis. I have shown that slide later on. So in our case, fever, splenomegaly, 5 out of 8 criteria are fulfilling. So we have done that. This is a case of secondary HLH. Now go to the progression of our patient. There was worsening clinical condition in next 24 hours, which further increases in peak pressure, decision to prone ventilation, and continuous infusion of neuromuscular paralysis done. Blood pressure was 70 by 43 in the meantime. Heart rate was 170, CRT was 4 seconds. Fluid resuscitation done and started on noradrenaline. Started on micafungin, along with due to there was a blood culture report of candida, while meropenem and vancomycin was continued. We have completed 14 days of micafungin from the last negative fungal culture, and meropenem vancomycin continued for 4 weeks. Patient developed pulmonary hemorrhage in the meantime. For macrophage activation syndrome, or HLH, we have put the child on IVIG, pulse methylprednisolone. The ferritin level was checked and followed. Pediatric rheumatologist opinion taken, and intravenous injection of anakinra was started. Investigation continues to search for the reason of recurrent mass or HLH. The right side of the slide showing a picture of how prone ventilation help in ARDS. If we see in supine position, the heart taking a large cross-sectional area that putting pressure over the lungs, does not allowing the lungs to expand properly or does not allowing the alveoli to recruit properly. If we done prone ventilation, the pressure over the heart goes to the lower side, and as the lungs goes upper side, it helps in inflation of the alveoli as well as recruitment of the alveoli. Though in pediatric age group, no proper recommendation is present. In adult case, it was seen that 50% of mortality used to reduce by prone ventilation. And this was the fever trend. We have given a chart from day 2 to up to his discharge. There is one day 51 or 52. There was from day 51, day 31 to there was from day 31, 32, there was no fever. But before that, there was fever. And this is the pulmonary hemorrhage slide, chest X-ray report. We show pulmonary hemorrhage. And this is the ferritin follow-up and check level. And in the past, we have given IV pulse, methyl prednisolone, and IVIG. Then ferritin report, ferritin goes down. In the meantime, we have taken the rheumatologist opinion. As per his advice, we have started anakinra. The IV anakinra, the ferritin level goes down. As per advice, we have started subcutaneous anakinra. Ferritin level again shoot out. Then we have given IV anakinra again. These are therapies for pediatric ARDS, PALIS 2 guideline. These are the good practice statement, very low certainty of evidence, moderate certainty of evidence, and cannot recommend for or against. The ECMO has very low certainty of evidence. The equipment maneuver cannot recommend for or against. High frequency ventilation cannot be recommended for or against. Prone positioning cannot recommend for or against. Means we can do, or if we decide not to do, we can also stay on to our decision. Then inhaled nitric oxide, there was low certainty of evidence. Neuromuscular blockage, very low certainty of evidence. Then come to the intubation by level of NIV, depends on how much our SF ratio or how much is our oxygenation index. If SF ratio is to use for severity grading in non-invasive ventilation, that is BiPAP or CPAP, or even on BiPAP or CPAP. Then when we go to our intubation, in that case, for severity stratification, we use the oxygenation index. The more the oxygenation index is, the more severity is. PEEP at or above low PEEP or high PEEP infrared to table can be seen, that shows moderate certainty of evidence. Volume we should start at 6 to 8 liter per kg or 4 to 6 liter per kg. But we should not go high volume. The plateau pressure less than 28 or diving pressure less than 15 centimeter of water should be used, and saturation criteria should be used to monitor the patient. That is, we should not go for hyperoxia or hypoxemia. That means we should not go for less than 88% or more than 97%. Then targeted fluid management has low certainty of evidence. We can restrict the fluid or we can give the fluid as per requirement depending on urine output as well as patient's clinical condition of volume overload present or not. And we should check the monitor or respiratory effort, targeted sedation management as well as adequate nutrition. These are the good practice statement. It will help our patient to come out of the ventilation as soon as possible, because prolonged ventilation is a problematic. It will create further complication. Now further progress, clinical improvement with improved compliance, improved oxygenation and ventilation occur. After 72 hours, increased secretion with deteriorating again oxygenation and worsening of the radiology occur. Temperature again spike, raised TLC, raised CRP, suspected ventilator associated pneumonia, antibiotics upgraded, iodine culture. ET respiratory culture shows XDR Klebsiella. We have started on ceftazidime avibactam sensitive antibiotic. Right side has shows that ET culture report of Klebsiella pneumonia. So in the meantime, we have also tried to diagnose what are the secondary causes of HLH in our patient.
Let me just ask you one thing. So you never grew anything from your initial cultures, yeah?
No, sir. Initial blood culture was positive for Candida albicans.
Oh.
That's why we have started on Mica fungi.
Okay, so initial culture showed candida. Yeah, okay. Maybe I missed that. Okay,
In the
sorry,
meantime,
carry on.
the patient was improving, but after 72 hours of ventilation, then again the patient was the oxygen.
Yeah, I
oxygen
got
was
it. Got it.
hampered.
Yeah,
Thank
yeah.
you.
Carry on.
So in the meantime, as there was HLH, we are suspecting some secondary cause which may cause that flaring up or that reactivation of HLH or reactivation of that hyperinflammation. For this, we have stated some differential diagnosis of secondary causes, that is infective endocarditis, tuberculosis. Those diagnoses are also present of prolonged fever of 6 months also there. So we have kept into mind for these differential diagnoses as also there was so those DDRs are hematological malignancy, hematological disorder, or sepsis. So modified Duke criteria was not fulfilled as blood culture report doesn't show any typical or atypical organism for AE. Echocardiography does not show any endocardial involvement, no vegetation or no mass is seen. This is the echocardiography report that shows only a small perimembranous VSD. And this is the culture report that shows Candida albicans. We have ruled out tuberculosis as there was no history of contact of tuberculosis. AFB stain on ET aspirate was negative, and gene expert on pericardial fluid and ET aspirate was negative. ARDA level in pericardial fluid around 60 unit per liter. And this is the AFB stain report, no acid fast bacilli seen. And this is the gene expert report on ET tube culture, ET tube aspirate, and this is the gene expert report on pericardial fluid. And this is the ARDA level that was 60. Hematological malignancy, we have also suspected. We have done peripheral blood smear that doesn't show any atypical leukocyte or blast. Bone marrow examination does not show any blast cell. Instead of it, it shows hemophagocytes. This is the bone marrow examination report that shows presence of few reticulum cells, shows hemophagocytes. Rheumatological disorders was ruled out as there was no history suggestive of joint swelling, joint pain, fever with evanescent rash. There was persistent rash. No history of hematuria, past cell in urine, involvement of uvea or recurrent oral ulceration. Investigation like RA factor, ANA, P ANCA, C ANCA, all are negatives. This is the ANA report which shows negative. We have done blood cultures and urine cultures that show growth of Candida albicans. So in blood culture as well as urine cultures, there was Candida albicans. So we have suspected this is a fungal sepsis that causing or activation of MAS or HLH. As fungal, we have suspected this fungal culture may come because the baby was getting prolonged treatment outside of the hospital for long duration. So final outcome was that treatment for HLH continued with intravenous anakinra, oral prednisolone. For XDR Klebsiella, treatment with sensitive antibiotic done. On day 27 of PICU admission, patient extubated to NIBPS. NIBPS continued up to 51 of PICU admission. Then moist O2 given with nasal cannula, maintaining a saturation of 95%. Her complete blood count normalized, ferritin level decreased to 16,000. Finally, she was referred to AIIMS Delhi for stem cell transplantation. And this is the last Excel report which we have done before referring the patient. And this is the patient who was going to AIIMS for further treatment. And this is some discussion on hemophagocytosis, lymphohistiocytosis. So this is a syndrome that characterized by severe systemic hyperinflation, which clinically present with unremitting fever, cytopenias, organomegaly, that is hepatosplenomegaly, and raised inflammatory biomarker. Patient often develop multi-organ dysfunction like liver failure, neurological issue, coagulopathy. If untreated, there is delayed diagnosis. This syndrome can have high mortality rate. This syndrome is characterized by tissue infiltration by activated CD8 lymphocyte, activated macrophage, and hypercytokinemia are the classical features. With characteristic morphology of normal macrophages by light microscopy and phagocytic cell for CD163 positive, but negative for other markers of characteristic of Langerhans cell histiocytosis like Barbic granule CD1, CD207. So there are two types of HLH, primary HLH caused by either mutation that are inherent to the individual, which I've already discussed, FHLH 1, 2, 3, 4, FHLH 16, and other syndrome that also causing FHLH like Griscelli syndrome, Chediatigasi, and X-linked lymphoproliferative disorder, ITK deficiency, X-Men syndrome, etc. And this is the pathogenesis of HLH. That is, there is a viral infection that is attacked by CD8 cell. CD8 cell activated because there may be problem in perforin and as well as granzyme enzyme. They're not able to kill the bacteria. There was persistent inflammation. Due to that persistent inflammation, there was secretion in interferon gamma that activates macrophages. That macrophages further secreted TNF alpha as well as interleukin 6 that further activate the macrophages, which causes phagocytosis of the virus as well as hemophagocytosis, patient's own cell like RBC, etc., other cell line also. That's why there is decrease in cell line. And this is the secondary HLH, which has a whole long range of differential that cause secondary HLH. In our case, it is a fungal infection due to Candida albicans that causes or reactivation of HLH. And this is the macrophage activation syndrome. The rheumatological encounter of HLH in patient with systemic psoriasis is called MAS. HLH in this setting is called MAS. And both disorders present with hyperperitonemia, high fever, cytopenia as well as organomegaly. Both, if untreated, can lead to severe coagulopathy, multi-organ dysfunction as well as death. The criteria that encompasses similar variants as that of histiocyte society, but different cutoffs are used. The cutoffs are, in case of macrophage activation syndrome, is more than ferritin is more than 684, platelet count less than 1.8 lakh, ALT level more than aspartate aminotransferase levels more than 48, triglyceride level more than 156, and fibrinogen level less than 360. Thank you. Hello.
Right. So I'm a bit confused. So what is the what is MAS?
MAS is the hyperinflammatory syndrome that used to occur in a rheumatological disorder that is also similar to secondary that is also similar to HLH, but different cutoffs are used for diagnosis of MAS as per
Right. And you don't think your patient had any rheumatological condition?
Yes.
So it is not MAS.
Yeah, it is not MAS.
Your patient is not MAS.
Yeah, it is secondary HLH.
Yeah. So I think in one slide you said it is a patient of MAS.
Firstly, we are suspecting this is a case of MAS.
Okay. So, but it is not, right? So that is ruled out because you have reasonably ruled out any rheumatological disease.
Yes.
Yeah, and if you are not, MAS is HLH with a background of rheumatological disease, right?
Yes, sir. Yes.
Yeah. Okay. Now, is this a primary HLH or is this a secondary HLH?
This is secondary HLH because the previous report in CMC Vellore, next genome sequencing doesn't show any gene that is related to primary HLH in this patient.
Right. So we think it is a secondary HLH, but this patient has got some features of primary HLH.
Yes, there may be some kind of. Yes, sir.
Which is primarily the recurrence, isn't it?
Yes, sir. Yes, sir.
That's why secondary HLH recur.
Yes, sir. But the cause was not found. That's why we have to still say this is a secondary HLH because the genes that are involved in primary HLH was not found in next genome sequencing.
Right. So that's
interesting. The thing is that
there was study that's showing that there are some variation in genetic sequence. There is some variation in genes that are prone to develop HLH, but those are not actually stamped as primary HLH. That kind of sequencing may be there.
Yeah, so that this is an evolving thing, isn't it? I don't think we have quite got the whole exome sequencing fitted to each diagnosis as yet, because as new data come in, the database is improving every day. But as
and another very interesting thing is, you have mentioned that they are going for a stem cell transplant. Yes.
Yes, sir. Yes, sir.
And stem cell transplant is a treatment of primary HLH, not of secondary.
Primary HLH.
And it is not a treatment of secondary HLH. So for
Yes.
all practical purpose, I don't know. I mean, I would also ask Shomenda's opinion on this. For all practical purpose, to me, this is a patient of primary HLH whose genetics we still don't know.
No. Yes, sir.
Whose
I think I
genetics, it is not within the list that we have got, and we are sure that there are other genetic variants which also cause the same phenotype, which we will know, and it is possibly one of those. So
Yes, sir.
it is for all, to me, for all practical purpose, it is a primary HLH whose genetics has not been, unraveled yet. What is your thought, Shomenda?
Yeah, I completely agree. I don't think that fits with secondary HLH because since 3 months, this child is having these episodes recurrently. I think every time, as far as I could get it, every time you come down on the immunosuppression or prednisolone, corticosteroids, the child has a flare up. That's not a pattern of secondary HLH. And you'd expect a fungal infection in these kids sometime if you're giving this much steroid. So I think this episode is just a flare up. The fungal infection is just by the by, I think. And just genetics is the I don't think we have got the complete knowledge of the genome associated with primary HLH yet. So this might be another variant and will eventually be included.
And if we think that way, then another thing which again crops up and which I find interesting is that anakinra for HLH is a new thing. Is a real is a real new thing, and it is used. Anakinra for HLH is used almost exclusively in a background of secondary HLH.
Yes, sir.
And for primary HLH, we have classic drugs like cyclosporine,
etoposide.
Right? Cyclo and etoposide. And it is interesting that here we have used anakinra, where for all practical purpose, this kid looked like a primary HLH.
Yes. But as there was no genetic codes, we can't stamp it actually.
So may I pip in? May I pip in?
Yeah, sure.
With Dr. Meur and Dr. Ogishekar Saha. In fact, the first HLH was admitted in ICG in my unit, Pritha. So what Ogni was trying to point out that it was not a case of mass. No rheumatic conditions was associated with it. The child presented from 3 months of age. So most probably it is the primary HLH, what he has pointed out. Secondly, what sequencing he has done, it's a whole genome sequencing or next generation XM sequencing, because I have not seen that particular report. If the patient is just 2 years old, so he must have that report. So sometimes the whole XM sequencing may miss, but it is cheaper than whole genome sequencing. So whole genome sequencing would have been preferred, particularly in this child where there is some suspicions of the primary HLH or not. And as secondary HLH, due to the candida applicant, I cannot support that because as she was getting the immunosuppression, most probably the child developed some fungal infection. And the lung, you have said that the lung contains hemorrhage. There is another conditions I have reported also.
So sir, there was a
lung
platelet count also there.
MAS with lung disease. Had the child been suffering from MAS, and with this radiological picture, I would have been going in favor of the MAS LD syndrome. It means the macrophage activation syndrome with the lung disease. We have already presented this case. So I think anakinra, what Ogni has pointed out, yes, it is the treatment for the SOSIA, which is not amenable to common drugs. Sometimes we have used the thalidomide also, because I was working in ICH, and ICH got the highest registry of this HLH and the SOSIA because Priyankar was there. So thalidomide has...
Priyankar is here as well.
Priyankar is there. So
sorry for joining.
Your name is not given. So you are behind, but Srija Rai Chaudhary, our first case of HLH admitted in our unit. So I have got that file also. So it was a whole mess of this thing. I think Priyankar is there, so Priyankar can easily just give his expert comments on this particular case. Why you have used the anakin?
First of all, I'll take a,
You want
I'll just apologize me for joining late. Shatarupa actually informed me last night, so I was had some family obligations today evening. So sorry for joining late. So actually, I was involved in managing this patient. I had seen the patient only once actually. I had visited the patient only once, but Shatarupa used to discuss the patient with me. During the entire stay, I think I was involved with this patient. So this was a Down syndrome baby who was presenting with a unremitting fever with some features of macrophage activation. Initially, I think diagnosed as MISC. Then they went to velour. But what I gathered, the child was almost steroid dependent. So whatever drugs you give, if the child is off steroids, the child would relapse. Even cyclosporine, I think someone had started over there. Possibly the velour people had started. So even the child was not responding to cyclosporine. So, so I thought that possibly we are dealing with a autoinflammatory syndrome, not a familial HLH or I personally believed it was an autoinflammatory syndrome who also can develop recurrent episodes of macrophage activation. And that was the reason that we initiated the child on anakinra from the very beginning. The child was on anakinra from the very beginning almost. The child had a very stormy course, recurrent episodes of infection. Of course, the child was grossly immunosuppressed. So that was actually the thought. Although the genetic panel was normal, but again, in autoinflammatory syndromes, 70% of them can have a genetic. It's a genetic diagnosis most of the times, but again, in 30% of patients, you can have normal genetic study. So we recently also had a baby in ICH, small baby with some. The child was having some other problems as well because the child had delayed development, recurrent aspirations, and this child around 8 to 9 months of age started developing this high remittent fever along with rashes and high inflammatory markers. So we also thought, but again, that by babies also the genetics were normal. The genetics were normal in that baby. So we initiated the baby on steroids, but we again offered them that you can go to PGI Chandigarh, which is possibly the biggest center for having the maximum experience in these patients. So this child is presently in PGI only. In fact, they have not been able to prove anything, but they think it's an interferonopathy. And this baby is on anakinra and baricitinib, so JAK inhibitor. So it's a combination of anakinra and baricitinib. This baby, in fact, the baby is, this month beginning, we had been to PGI Chandigarh. The parents came, they were in PGI, so the parents visited us. In fact, there was some neurological improvement as well in this baby. So autoinflammatory syndromes, we are still trying to understand this entity, which is quite new for us, autoinflammatory. And I believe that this Down syndrome baby also had a autoinflammatory syndrome and this recurrent episodes of macrophage activation. And that was the reason we kept the baby on anakinra.
Do you treat them with this stem cell transplant funda?
Yes,
I mean,
see the
that
X-ray.
is the curative
X-ray
treatment.
is showing the radiographic shadows bilateral. So why don't you think it is a mass with the LD, lung disease? There's one entity.
Those still happens. So those can go on happening, this and that. But the basic diagnosis, what we thought of was an autoinflammatory syndrome with recurrent macrophage activation.
So now the final diagnosis from you, is it a mass primary or secondary HLH or autoinflammatory syndrome, as it was been pointed out by Dr. Joyant Muduri of IQCT also, autoinflammatory disease. 2 years back when I was in Durgapur IQCT hospital. So
I mean, what are
confident
the
about
diagnostic criteria of autoinflammatory disease?
Autoinflammatory
Educate us.
recurrent episodes of fever and hyperinflammation.
This
So
is a
same
generic
as an
diagnosis,
same
expert.
is it?
happens in
Or
primary HLH.
So
So
there,
Priyanka, as an expert, what is your final diagnosis of this case? Presumptive diagnosis.
presumptive diagnosis was an autoinflammatory syndrome with macrophage activation.
Okay.
So because it was not falling into any known category of disease. So because we did not actually really think of a genetic HLH, familial HLH. Otherwise, we would have given etoposide from the very beginning. Etoposide does wonders in patients
Srija
with
got
familial.
etoposide. Srija got etoposide. Srija was then taken to Hello, the first case, our first case. And
Srija,
she
so,
was given etoposide.
she received etoposide, yes. She received etoposide.
But
yes.
you can publish this paper. You can publish the paper. There's mass with lung LD. We have presented the case also. The mass with LD. Because we couldn't explain, then we
I
searched and
presume
got
that
one
the
case
baby
I
has
can
gone to
share.
AIMS. So, is there any update from the AIMS people?
Yes, actually, they told me that she actually we got a call back from the mother saying that she's on tocilizumab. They've started tocilizumab, and it seems she has improved. And they also detected CMV, and then she's improving. That's what so far that was around 2 weeks back. That we don't know.
And that also makes sense, isn't it? He was on IL-6 inhibitors previous. Toci is again another, it works by blocking IL-6. So maybe his IL-6 was previously raised, isn't it? No, he was on some. His
As far as
IL-6
I
was
remember,
previously raised.
they had done one IL-6 report, but I don't remember CMC. Most probably, they had lots and lots of reports. They have been visiting CMC twice, but IL-6, whether it was raised, I don't think so. But here we haven't done anything because of we already had a.
Have they done this whole genome sequencing or whole exome sequencing?
No, it was a NGS, next genome sequencing thing.
NGS is
No.
next generation sequencing, but you can
NGS
do
is
whole
a modality.
It's a technique. You can do whole genome or just the clinical exome bit.
Yeah,
We had just the report.
NGS is a technique. NGS you can do both. Yeah, sorry.
It just showed that NGS non-pathognomic variant of familial HLH. That's what. Otherwise, nothing was there. We did not. We just had that thing written.
Difficult to know.
So when we spoke to CMC also, they were also quite struggling because initially when the child came to us, she just got referred for vegetation for removal in a surgical cardiac unit. So when we spoke to them, they were telling that she's really. We also don't know what's going on with her, and so even the stem cell transplant is the only option. After if she doesn't respond to anakinra or like that. And if she continues to be like this.
I think whatever it was, Shwatarupa and team, you have done a brilliant job keeping these children alive. Those of us who work in intensive care know these grossly immunosuppressed children, when they come to ICU, are a nightmare to deal with. I think well done. Great job done. Keeping this child alive is a struggle. Whatever is the diagnosis, I think we are not into that sort of sphere. We live day by day. So 51 days of struggle. So well done. And I think we can go back to the intensive care a bit, so that I think that would be the focus for this evening. So can you just go back to the ventilation and the associated support portion? Bhaskar, can you go back in your slides? Bit more. Bit more. Bit more. A bit more. A bit more. A bit more. Okay, stop there. Stop there. Stay on the X-ray. Okay, so how would you describe the X-ray, Bhaskar?
This is bilateral diffuse opacity which is present, and there is no focal opacity. Actually, it's a diffuse opacity, and that may be due to anything, due to edema, pulmonary edema. So in this case, this is a non-cardiogenic pulmonary edema. So we have think this is a air case.
Okay, so I think I can hardly see any lungs in this X-ray. I can see 2 airborne program, and that's about it. That's all the air there is. It's surprising the child is alive. What's that line? Is it a subclavian line?
Yes, this is a subclavian line. It's a tube.
Okay. So why did you choose PRVC as a mode of ventilation as opposed to other modes?
Actually, sir, in ARDS, there is no recommendation regarding the mode of ventilation. We have started PRVC because the PRVC will give less paratrauma to the patient.
Why is that?
Because in PRVC mode, the ventilator will try to give less amount of pressure to create the ideal amount of tidal volume that we try to achieve.
Okay, let me ask you one thing. Was this child muscle relaxed?
Muscle relaxation was given.
Yes, yes.
Yeah. So if you muscle relax somebody, then is there any difference in which mode you are ventilating? Pressure control, PRVC,
Actually,
or a completely
this,
control mode of ventilation?
Sir, this child was
As
actually
in
not on infusion of muscle relaxant. We used to use muscle relaxant during suctioning, and this type of procedure to keep the baby calm. Actually, we don't go for infusion of muscle relaxant. We go for intermittent muscle relaxant during suctioning as well as doing some ET tube change like this kind.
Sorry, I didn't quite get you. You're using muscle relaxant only during suctioning. Is that what you're saying?
Suctioning, ET tube change.
ET tube change must be a rare phenomenon. I'm sure you're not changing ET tube once a
No,
day.
No, actually, Bhaskar, just sorry to interrupt. Actually, yes, when the child was like this in this state, at that time we did start some muscle relaxant infusion. Then later on, we were just giving sedation holiday, and then we changed to intermittent. I think
that's what I'm asking, Bhaskar. Is there any difference in the way ventilator works if the child is muscle relaxed, whether you're in PRVC mode or pressure control mode?
No, sir.
Okay. So I think the advantage is that you get a predictable minute ventilation. That's about it. You'll get that with volume control as well. I don't think it makes a huge amount of difference which mode you are on once you are muscle relaxed.
Yes, sir. That's why no special recommendation on mode of ventilation regarding ARDS in pediatric age group. We can give any mode of ventilation.
Okay. And go to the previous slide. You chose a tidal volume of 6 mL per kg.
Yes, sir.
Was that based on actual body weight or ideal body weight?
Which was I was based on actual body weight because that is the current recommendation.
Okay, why is that?
Because predicted body weight may cause lower actually. If the baby doesn't grow properly, his lungs may not grow properly. So if we go for predicted body weight, that may cause delivery of high tidal volume.
Okay. Which parameter, which anthropological measurement correlates best with lung volume, do you think? Is it weight or something else? Sorry,
it's height actually.
Yeah. So it's not anybody's fault that the The formula is not there still, but I think height would be the most useful criteria to use. So if you choose modes like ASB and things like that, that's why they ask for the height these days. But what algorithm they use to choose the ideal tidal volume is not made public, so we don't know what formula they're using these days. Okay. What inotrope did you use for this child? Noradrenaline, is it?
Yeah, we have started noradrenaline first actually.
Okay, why did you choose noradrenaline? Again, same question as I asked Shreya.
Actually, we should start with adrenaline, but there was
Why do you think adrenaline?
Because that is the
If you-
recommendation that if we
Where?
go- Yes, sir.
What is the recommendation?
Because sir, adrenaline will work on two things, as well as it will stimulate cardiac, as well as it will create peripheral vasoconstriction. So it will maintain systolic as well as diastolic blood pressure both. But if there is one septic shock, there is only vasodilation. That cytokine doesn't affect heart first. If doesn't affect heart, in that case, we should go for noradrenaline fast, because noradrenaline actually works only on a higher percentage on alpha receptor, that is on peripheral vasoreceptor, peripheral vasoconstriction, that will not create strain on heart actually.
You're saying noradrenaline will not create strain on heart.
It will create some kind of strain by increasing afterload, but it will not increase heart rate, as well as it will not create any conduction, means stimulation of the heart muscle actually.
Okay.
It will
Do
specifically
you want to stimulate your heart muscle, or you do not want to stimulate your heart muscle?
If there is only diastolic BP fall and there is only peripheral vasoconstriction, I don't want to stimulate heart muscle first. I go for peripheral vasoconstriction first.
Okay, let me ask you a different question, or the same question in a different way. If everything else is equal, and if you increase the afterload, only the afterload, what will happen to the stroke volume and the cardiac output?
Stroke volume, cardiac output will decrease.
Okay. So if you're giving somebody noradrenaline, do you keep that in mind? Do you take that into consideration, that it will actually, if it increases afterload and if you haven't compensated for it in any particular way, that might decrease your stroke volume and cardiac output?
I don't think so, because there is already vasodilation, and due to vasodilation, I am just normalizing the vessel by vasoconstriction. I am not over constricting the vessel.
So are you saying that you are actually, that the child is in a high output state, you're just normalizing it?
Exactly.
Okay. Ogni, do you want to say anything about that?
One thing, when you say, when Shomenda asked, if you increase the afterload, will your what will happen to your cardiac output? Will it always fall?
No, sir.
Right. When will it not fall?
If it goes beyond physiological limit, then it will fall.
And when so it is in that Starling curve, no, that if your suppose your afterload is increased, so you are having more blood in the chambers at the end of diastole, that is causing stretch of your muscles. And if the stretch of your muscles, and you are in that space where that actually, that itself, the stretch itself cause increase in the inotropy, which can happen physiologically, and then it will, whatever extra amount of blood is there, it will push it out.
Yes, sir.
No, so then you don't need that, but it will happen when only you are overcompensating, you are going beyond the limit of that thing, when your Starling curve goes to sag down, when your inotropy is so much, when your afterload is so much that the Starling thing is not, that is not enough, and you are, and that is when your heart will start to fail.
It is living beyond the sigmoid portion, it is going to the stat portion.
when it is sagging down, yeah, then that, so it depends on where your heart is actually. But what was the question, Shomenda? Sorry, I forgot.
That was the question. I wanted to come to a separate, a different discussion. If you talk about a single Stirling curve, I'm not talking about family of curves. If you talk about a single Stirling curve, that doesn't actually take into account your afterload bit. So it's the LVDP and your stroke volume is what's plotted in there. In theory, if my cardiac output goes up, if you look at the ventricular pressure volume relationship curve and the arterial elastance, then obviously increasing afterload will result in a fall in cardiac output through fall in stroke volume. But there is something called ventricular arterial coupling. So that's something adult physician use for the basis of their treatment with noradrenaline, even in heart failure. They'll give noradrenaline to people with, say, myocardial infarction who have come with low blood pressure. So they use this thing. The belief is a strong word. So ventricular arterial coupling is like if you increase the afterload, it actually increases your contractility. There is no direct proof of this, but there are lots of discussion and there are some animal models showing that there might be an increase in contractility with increase in afterload. So in a low blood pressure situation where your cardiac output may be adequate, but your perfusion pressure is not adequate, you may consider giving just noradrenaline, and that might increase your perfusion pressure. And the cardiac output may not fall because ventricles have the ability to compensate for that extra afterload, because all ventricular fibers are not in work at any given time unless it's working at the extreme. So if you are in like myocarditis or thinned out myocardium and those sort of scenario, the myocardium will have quite a bit of reserve. So all the myocardial fibers are not working at the same time. So if you increase the afterload, further myocytes can be recruited and you can compensate for that loss in stroke volume because of increasing afterload. That's what I was trying to get at. So yeah, noradrenaline can be an appropriate drug in this situation. It will not necessarily cause a fall in the cardiac output, though theoretically it would.
10 o'clock now.
Now the time to conclude. Will you stop sharing, Bhaskar?
Okay, sir. Thank you.
So thank you, Dr. Bhaskar Banerjee, for your elaborate presentation. And you have gone just like the PGTs, although you are not PGT, like the chief complaint, present illness, past, examination proper. This is the protocol that we want in this Sandhya Pathshala. So I'm really indebted to Dr. Soumen Mehul and Dr. Abhishekar Saha for their expert opinion. And I'm also thankful to Shatarupa Mukherjee and Dr. Satyabrat Raichaudhuri as the mentor of the two cases. And the presenters also, Shreya Haldar and Dr. Bhaskar Banerjee, for presenting their cases. I'm really thankful to the audience. In fact, even the match is continuing. There were 52 at one time. Now it has come down to 21, but there was at one point there was 52 even on Sunday, and there was a match. And on behalf of West Bengal Academy of Pediatrics, I thanks all the presenter, mentors, and the expert for your valuable contributions in this Sandhya Pathshala. Thank you and good night. So hope to see you again in future